Dr. Joe, it is my honor to introduce you as the OEDI speaker for the Addressing Structural Racism series. And I look forward to learning more about the things that you have been doing with your career, particularly in underrepresented groups and those that are groups of color. So thank you.
I want to thank Dr. Kearney Ramos, everyone involved, Dr. Mann. It's a long list of wonderful folks who invited me. Dr. Span, invited me here today, Dr. Rosales. But anyway, that was a long introduction to say thank you. I appreciate that. I'm not going to take it that you say I'm old, but I'm just going to say that I've been around for a little while. So thank you very much. So I know I've shortened you in time, so I over-prepared for this conversation. So hopefully, both in chat as well as the leadership here, you can stop me at any time should you want to ask a question. But I have a lot to get through because I thought what a wonderful opportunity it was when I saw the framing of this series, looking at structural racism. I said, wow, Columbia University, as a New Yorker, I was like, yes. Let's talk about this. I said, you know what? I'm not going to move away from what I would want to talk about. I'm going to try to center it in things I've been thinking about relative to this, and hopefully I can offer some thoughts and some insights that might have some bearing, whether it's on the research agenda for those who have it, or considerations for direct or clinical care as those who are doing it, or for those who are doing both. So my question today is suicide risk as a consequence of structural racism. So I want to thank all for this invitation. I had no financial disclosures or conflicts at all, so I wanted to share that. My objective was to, when I thought about this, and I said, well, I wanted to examine this issue of suicide risk as a consequence of structural racism, not only from a personal point of view, but then again, I find myself reflecting on the address by then 38-year-old Dr. Martin Luther King, when he addressed the American Psychological Association. It wasn't American Psychiatric, it was American Psychological Association. And then I was reflecting as I was preparing for this talk, I found that the American Psychiatric Association had a task force on structural racism that was launched in 2020. So again, thinking deeply about this conversation, I wanted to ground myself in the home for which I've been invited. And to do so, I'm going to try to cover broadly kind of the historical positioning of economic and emotional well-being experiences of Black Americans and how it's tied to our intentional actions reflective of how we either dehumanize individuals or we differentiate opportunity through structures in our society. I'm hoping what would happen is as I talk about this and I talk about what's happening in terms of suicide risk among Black Americans, that I'll be able to make a connection between this issue of structural racism and how it relates to the suicide risk as a consequence. So in the end, I'm going to try to leave you with some of the learnings that has come about from my work with my colleagues here at the Race and Opportunity Lab, related to how you take a really anti-racist approach to human interaction. And I'm going to say that broadly because it could apply to both science as well as clinical practice. So there's a lot for me to try to do in a short amount of time that I've given myself. I know you've given me more. And again, just to remind those who might not be familiar, this is in 2020, APA, American Psychiatric, launched this task force to address structural racism throughout. And I want to emphasize the throughout, throughout psychiatry. So if you have not looked at it, please take a look at it. I do think it's worthwhile. But I want to highlight, they said they want to provide education and resources on APA and psychiatry's history regarding structural racism. That means acknowledging that psychiatry is complicit in experiences that could be determined as racism-based, or reflective of structural racism regarding, again, those who are in the profession, who gets into psychiatry, who gets trained, what happens to their scientific contributions, et cetera. They also highlighted explaining the current impact of structural racism on the mental health of patients and colleagues. And again, this is 2020. That means it's in the context of the pandemic, in the context of George Floyd, and the increased awareness that racism, particularly structural racism, had has an impact not only on our past, but our current, and hopefully we can reduce its impact on our future. So if my slides are not showing, please somebody let me know because I cannot tell. So they also highlight developing achievable and actionable recommendations for change to eliminate structural racism within APA and psychiatry now and in the future. Again, and some things to the board. I wanted to bring this up because it also signals and is also aligned with what Martin Luther King was talking about in 1967. So the APA task force, and I love the statements by the then president and as well as the CEO, acknowledging that this history of APA in terms of, again, going back to its very roots in the 1700s and how it scarred and how it had impact, not only in structural racism, but this is the key part for our discussion today, racist ideas. So also, as that medical director had said, we have not done enough in the past as a field or as an organization to ensure that Black people, as well as other minoritized communities, are treated fairly and equitably. Again, a key part of what our conversation today could be about. So there was a call to say, help us dismantle the systemic racism that impacts so many of the colleagues in APA and in departments of psychiatry, and as well as other applied and helping professions, social work, and others, and those that we serve. I thought this was the right context to frame a little bit of what I might say. Then I reflect on Dr. King's opening remarks. And his opening remarks was really an address to what he calls social scientists. And that's how he framed us. But again, it relates to us. And he says, always a very rich and rewarding experience when I can take a brief break. He can take a brief break from the day-to-day demands of our struggle for freedom and human dignity. Why did I reflect on that? Because again, what King was saying is that there are those who are on the front line dealing with these issues of trying to bring about a more equitable society and how that is a day-to-day demand and struggle. But he thought this was a brief break from that to come and speak to those who are advancing science that has a particular impact on how we experience our country, as well as how we cope with life in our country. And he said he wants to discuss these issues involved in the struggle with what he called concerned friends of goodwill all over the nation. So as you reflect on the APA task force and other colleagues and even those who might be present, we all, I believe, are those of goodwill, and many of us are striving to ensure that we address anything that will continue to further racism in any form that it takes, whether it's structural or at the individual level. We feel our nation could be better off. And if you speak to concerned friends of goodwill, that's all over this nation, that we can advance our country in this way, again, towards a more perfect union. So again, I felt it particularly, he talks about the privilege of having this space to talk with the academic community who are writing and dealing with the problems that we face, and racism and structural racism is one of those. And you have tremendous responsibility because you are shaping the minds of the young men and women all over this country, and you're providing critical care for those who are having a difficult time in terms of how they're experiencing the world as it is. So again, I really centered on this idea of King focusing on this idea that, you know, recognizing the distance between what we tend to do in the academy and what's happening on the ground, but also the important that we have to lift up in our work and understand the day-to-day struggle for human dignity is part of what we are doing as clinicians, as psychiatrists, as social workers, or as those who are advancing science, to say we can help to make people's life a little better and help them cope with the challenges that they're dealing with, and to join in this struggle for advancing equity and human dignity and democracy is all part of our responsibility. So it's part of our important responsibility, and we must face this on a regular basis. So another piece I want to do is to just take a little context. I'm going to speed this up because there's so much I wanted to get across, but let's make sure that we have a good understanding of what we're talking about. So structural racism, first we must understand racism. And I'm going to do two things real quickly. One, racism is the regulation of racialized, that means you must racialize human beings, put them into these categories that we call races. And then we must minoritize, that means you must give them certain social, put them in inferior social statuses, and the treatment that results from those statuses, which are often based on unfounded beliefs. That means the science has not proven those beliefs to be true about the innate inferiority of a group, and as well as any unjust treatment or oppression of people of color, whether intended or not. And this is what we refer to racism. Racism is action. Racism is verb, right? So you must think about it in that way. Racism is not always conscious, intentional or explicit, but it's often also reflected in, as in Zimbrana and Williams summarized, in systemic and structural ways. So let's talk about that. Systemic and structural racism are forms of racism, pervasively deep and embedded in and throughout systems of care, systems of education, systems of law. They're written and unwritten policies. They're entrenched in our practice or praxis. They establish beliefs and attitudes that produce, condone, and perpetuate widespread unfair treatment of racialized and minority persons. So I wanted to make sure that we have this sort of definition so that at least, as I mentioned some other things fairly quickly, that you remember that we're talking about things that are part of how structures operate: educational systems, employing systems, legal systems, incarceration systems. It's also in education, academic systems, clinical practice, hospitals. Those are all systems that we go to for care, for growth, as we say, skills building, whatever. But again, some things are established both in beliefs and attitudes that produce and condone this sort of unfair treatment for racialized and minoritized groups. So again, systemic racism, some language you've heard, and I'm just trying to add a little more specificity. There's structural racism, institutional racism. And again, we hear this language of what do we really mean? We're talking about whole systems again, whether it's political, legal, economic, healthcare, school, as I mentioned, and to emphasize the role of these structures in our lives. These systems are scaffolding. They allow us to heal, grow, and thrive in American context. So when we think about structural racism, which is often used interchangeably with systemic racism, we're talking about these systems. And then sometimes we're talking about specific institutions, and that way we call out what's called institutional racism. So again, they often use a synonym for systemic and structural racism, but sometimes we call out a specific institution, a specific school, a specific department, a specific hospital, a specific police station, or a specific particular incarceration facility, as example. Now, there are many ways to think about structural racism in health, whether including mental health. So let's understand some of these pathways. I'm just going to highlight a few. There's been, again, these things are well documented in science and literature. And again, should need be, I can provide references for many of these things. I'm just citing some of these things. So again, we have a common language and a common thought ways to think about how suicide could be a consequence of structural racism. So structural racism pathway can disadvantage people economically, and that can harm health by placing people in economic disadvantage that leads to poor access to care or result in discriminatory obstacles to economic resources and opportunities. And these pathways can particularly harm health. And again, there's numerous scholars from Williams, Zimbrana, lots of folks who have done this work. There are numerous racism-based obstacles to economic opportunity. For example, the lack of access to good jobs, which can lead to lack of access to good food, which can lead to lack of access to good housing as a result of redlining and other things that's well documented. If you don't have good shelter, shelter is one of those key social determinants of health. Shelter matters in many ways. And again, economic disadvantage that is put in place, because these things are intentional first, and then sustained. That means there are practices that sustain them over time, whether it's law, attitudes, and then eventually implicit, if not explicit, biases. So hence constrained economic opportunities, again, through poorly resourced schools, lower levels of income, lower levels of wealth, lower levels of education, because knowledge, right? Health belief model, knowledge matters, repeatedly contribute to ethnic disparities in health. Another mechanism through which this happened is dehumanization and disenfranchising people. So depriving them of the right to vote as an example, which is disenfranchising, decreases the weight of their vote, weight of their collective power, the weight of the ability to determine what happens, that idea of local governance, determine what happens to their trash, what happens to their streets, what happens to how busy a street is, what sort of speed people are driving on those streets, again, governing their things that matter, these social determinants of their health. So these health damaging pathways occur. Political power matters. Again, the access to clean water. If you don't think that's important, look at the residents of Flint, look at the residents, again, in Jacksonville, Mississippi. These things matter, to have pollution-free neighborhoods, power and political power to exercise that, affordable housing, access to medical care. These things are impacted. But we also dehumanize as part of that. So systems also say people are of lesser value and seek to treat them that way, differentiating. Thus, there are disparities that are racism based and could be done structurally. Okay. And as I mentioned, another pathway is health harming conditions and limiting access to health promoting resources. These are all viable pathways through which, again, structural racism impacts health, including one's mental health, whether it's limited access to health promoting resources, again, educational opportunities, medical care, or the kind of chronic strain and financial strain that individual feels, which you can take as very stress diathesis model, where you're saying, well, how you feel about how you're living, how you're earning, how you're taking care of yourself or self and family has an emotional toll, which can lead to the onset of mental illness and other risk factors, or can serve as a triggering mechanism that can lead to a suicidal crisis. These are all, again, pathways through which structural racism can have an impact. Another one, of course, is we hear a lot more about, which is bias policing, and the work of Robert Motley and other young scholars who are really taking up this work to look at the consequences of these racism-based police violence and interactions, and what is the mental health consequences or developmental consequences, and how that impacts who's incarcerated. And if you get incarcerated, then there's a stigma related to that. You get out, and then there's a lifelong lack of access to resources and opportunities needed for health after incarceration. So again, this is the way structural racism can have an impact. This does not suggest that there are not individual level contributions to these things, but we're talking about spaces and places that have been intentionally deemed to produce these sort of results, regardless of the skin color of the individuals who live in those spaces. And again, we have seen this over time as we look at from the 20th century forward, different communities that has different immigrant groups, and has those groups change. The people change, whether it's Eastern European or it was Caribbean immigrants. These same neighborhoods tend to produce similar results because they're designed to produce those results, whether intentionally and again eventually unintentionally, because it's baked into norms. So these sort of thinking and work around structural issues and racism-based issues didn't start with the killing of George Floyd. W.E. Du Bois in the Philadelphia Story tells you about this, where he began to really do this sort of work, paying attention to, as King called us to do, this higher learning. King called us to do more, to pay attention to not only what's happening to those who have been marginalized and racialized. King called us to say, well, what is their lived experience? How they're experiencing change and progress or the lack thereof. And not only to pay attention to the group, but look at them as a whole. So not only the individual level determinants, but you must understand the social study, the social story, the sociology of the experience of these individuals. And he began that in his work with the Philadelphia Negro just as a young scholar. And if you read Philadelphia Negro, and then you read as he's talking about how he's advancing that work, you also begin to see some of the same factors that determine the careers of scholars of color who want to choose to focus on what's happening with their community, whether it's in psychology or social work or anthropology, and they want to pay attention to that. And he talks about his experience. Let me give you an example. One of the most learned men of the time, he's talking about the 1800s. And again, he was not even afforded an opportunity to get a faculty position. One of the most learned men at the time coming out of Harvard, and not even afforded that. Also, even when he got a position at this point in time at the University of Pennsylvania, he was not even afforded to be on the official roster. He was given some type of pseudo title, so he didn't have a real faculty position. But he took it as an opportunity to advance this work because, again, for his own needs, but also he thought it was important to do this. And when you look at Du Bois' work, it brings us in the context of one of my areas, because again, I did my postdoc at Penn, and this is the time I ran into this reading of Du Bois and really understand the parallel experience, even though hundreds of years later, about what's afforded to young scholars of color. But I was beginning to look at this because Du Bois, even in his work, The Souls of Black Folks, pointed to me in many ways the structural factors that were shaping the spirit of young Black Americans. And again, how that relates to their risk for suicide. So I'm going to, again, draw a lot here together, but I'm hoping some of what I shared in terms of the pathways and some of the things I would mention helps to make a connection, because again, I know there's a lot more we can discuss. So, but looking at Du Bois' work, what he lifted up, the importance of doing community level analysis and then doing both qualitative and quantitative work to get a deeper understanding of the lived experience. Because when we think about suicide risk, what are we really talking about? What we're talking about are individuals who are coming to a decision point that their death is of more value than their life. So it's not just what they're born with. It's not just what they might experience that shaped them in their formative years. But again, it's the cumulative experience, the multifactorial experience that lead one to experience or come to a decision, again, a reasoned decision, though it could be impacted by mental illness and other things, but it is a decision that says one's death is of more value than one's life. And again, when I think back on Du Bois and all that he was sharing with us, and then for all the scholars that came after, really looking at structural factors and how it's racism-based structural factor that set up the experience for the group I pay attention to in my work, primarily, which is Black Americans. Again, it speaks to the spirit of young Black Americans and their risk for suicide. And I'll share with you briefly why I'm focusing on young Black Americans, things to think about. So first, to understand suicide among Black Americans, and this pattern hasn't changed that much. And I just want to bring this to your attention in case you might not know. There are different patterns. This is just one example of suicide looking across the lifespan. And you see that for whites, which is this black line, Black white males, suicide tends to increase with age. The older they get, the higher the risk for suicide. The red line represents Black males. And again, you see it increases with age, but it decreases as Black Americans age. And then I can show you the 2020, and we're waiting for the 2021 data, it's the same sort of pattern. For white females, this gray line, again, increases with age, get to middle age, and then decreases over time. White males are the only ones who increase in risk as they age. And then for Black females, again, increases a little bit and declines over time. Just understanding these patterns suggests to us, again, who's most at risk. And this is why I say, for me, I'm looking at young Black Americans, because again, as you can see, for whites, white males, the suicide rates increase or peaks in the later years. For Black males, it peaks in that 20 to 24 year period. For white females, is middle age. For Black females, again, those under 35. So understanding that helps you to understand the developmental context that might lead to suicide among this population. And particularly as we look at when we say developmental context, we're talking about those structural contexts, as well as looking at their own individual agency and experiences. But again, that's conditioned, whether epigenetically, however you want to talk about it, it is conditioned by a person's fit within their environment. And in the work that we do, and we see very clearly, when you talk about suicide among Black Americans, you're talking primarily higher rates among males. Generally in the US population, suicide is usually like a 4-to-1 ratio, male to females. Male die more by suicide, female attempt more suicide, but male die more often. And look here, again, it's even a greater disparity between Black and whites. Well, I mean, Black males and Black females, as this slide shows. And regardless of the age group, this is what you see here is the proportion of suicides accounted for by biological sex at birth, males, and biological sex at birth, females. And you can see clearly that by the Black lines, male, whether it's 2019 or 2020, Black males account for most of the deaths among Black Americans, 82%, 80%, 70%. 65% if you're looking at 10 to 14. It's predominantly males are accounting for most of those deaths. Doesn't mean females are not dying by suicide, as you can see here, but a lot of the changes are not that great between the years, but again, males account for more of those deaths. Most striking, most concerning is, if you've been doing this for long enough, and this work was highlighted by Bridges et al. In 2015, and even with my more recent analysis I did in 2021, we began to see increases in suicide among Black children, those who are not even out of the second decade of life. And there was an 86% increase in suicide among Black children and a 32% decrease in suicide among white children. And for the first time, we had a record of subpopulation of Black Americans who have higher rates of suicide than whites. Stunning. But then you're talking about children who are making this decision, whether there's some undercount, whether there's some concern about how the data is actually documented. But again, this is our mortality data and we use it, who are making that decision that their life is of less value than their death. And then from 2015 to 2019, we saw a marked 52% increase in suicide among Black children. So what Bridges et al. Saw from 1993 forward to 2012, we still continue to see this marked increase in suicide among Black children. So things are not getting better. We have more concern. We have greater concern because of what we're witnessing among children. And again, we're talking about children under 12 as they show, and as I said, it continues to increase as both of these graphs show. We're concerned about the methods used. Firearm is the primary method used for suicide in the United States, and the same thing for Black Americans. So again, when we look at these issues of structure, we have to ask access to firearm. How is that done? Black gun ownership is not at the same rates of white gun ownership. We often tend to live in states, well, in the South where there's a lot of gun ownership. But again, the idea here is that how do Black Americans tend to have increased access to firearms, particularly when most of those deaths are not in the South, they're really in the North or in the Midwest. So again, where gun access is very much more limited, but we have to examine it from both a structural approach, because we're talking about structures that allow for guns to be prevalent within communities and people have access to them. Beyond the Second Amendment idea of a right to a firearm, we look at these guns and whether or not they're legal or not legal, we just don't know. And the reason we just don't know is a structural issue, because we're set up not to know. If we wanted to know, we can set up structures to know that in terms of the firearm, documenting them, understanding where they're coming from, having a history, but we set them up in laws and policies. So again, structural things. Critical for me to note in all, if I'm going to summarize this, and again, I'll connect it back to our broader theme, because I'm really trying to ask this question. Is suicide risk a consequence of structural racism? How do we begin to study and understand that? And clinically, what do we do if that is the case? And the point I want to make here is that among Black Americans, we're losing future generations. As I've shown you, for white Americans, whether it's females in the middle age or for men who are 65 and older, those are the high risk groups, you're losing past generations. That means those generations of contributions of economy to their communities, to their families, you're losing that collective knowledge and wisdom, you're losing that. But for Black Americans, they're losing the future. That means their children, that means the young adults. So among Black Americans born after 1976 under age 45, suicide is among the top 10 leading causes of death under 45. Among Black Americans born after 1986, that means under 35, suicide is the top 5 leading cause of death. And this is true for both men and women, sex at birth definition. Losing future generations. So the consequences for communities are very, very different. And we must pay attention to that. I know I'm using a lot of time. So, because I want to hear some important. So, as I mentioned, there's many pathways through which structural racism has an impact. So as you think about the suicide risk as a consequence, not only just for Blacks, but for all Americans. For again, we have a few things we can note. We note for the first time, according to a recent Pew study, that you have a generation of Americans, including white Americans, who feel that their children are not going to be better off than they will be. Never happened before. So again, we all are in this kind of structural framing that says economics and work is pretty important. We have greater, again, by a few scholars who identified, particularly among whites and white females as well, they're all suffering, we all suffer from the same process, that we look at our transition from adolescence to young adulthood and the ability to be able to go to work and earn to take care of ourselves and family. And we set ourselves up to say, well, how do we interpret whether or not we achieve those things? And we tend to now interpret it in a broad American framing as an individual level factor. That means I am not able to do. But then we're all impacted by these very structural issues. So whether it's racism-based structural factors or just structural factors that disproportionately limits the opportunities for whether you're Black or white, it all has a consequence. And now we're seeing that now in the patterns of suicide change among white Americans, because again, the suicide rates have increased overall for all of us. So the importance of work has an importance. And there's literature around this that says work underscores our positioning. It helps us to understand who we are. It provides a source of dignity and purpose, which is crucial. So again, one of the things we do in suicide research is try to understand people's reasons for living. And the idea of having purpose in one's life and dignity in one's life has a consequence for our mental health, or whether or not we use other things to cope, including substances, or has an impact on our ability to recover if we have those experiences. So again, priming the idea that suicide could be a consequence of these sort of structural factors. So again, we know the work of this scholarship on the work in recovery, again, that purposeful life, that self-definition, the meaning of it, the vocational future, the idea you have more to look forward to. Excuse me. Sorry, I'm back. So work provides for that. So let me skip past this because again, I don't want to not have any time for any questions, and I'm using up a lot of time. So I'm gonna go past this work and recovery. And we know that the role of work has significant benefits and is part of treatment outcomes. Go past that. So when we look at the overall experiences, not just of how we set up the work experiences for all Americans, but in particularly for Black Americans, let me connect it to, again, to the focus of today's conversation even more so. So we know population level change matters. That means what we're experiencing and seeing over time, since I know I've been doing this work, where in the 1970s, the suicide rates were higher among Black Americans 45 and older, well, not 45 to 55. Then it keeps, each generation goes down and down in terms of the idea that younger and younger Black Americans are becoming an increased risk for suicide. And now it's those under 35. And now we're seeing it's the 20 to 24 who has the highest risk among Black Americans. And now we're seeing Black children's rates increase higher than white children's rates. So again, we're seeing these population level changes. And what does that mean? That means the social lives of Black Americans. That means taking into account values and attitudes, social ties and connectedness, structural conditions, opportunity, and as well as the African diaspora begins to either assimilate into the broader American culture and how we interpret our lived experience, or for those who are more recent, acculturate into that process. So these level changes are critical things to try to understand how suicide risk is a consequence of structural racism. To further say a little bit more, and I'll move because, again, I am contending, I've had for a long time, that this is a new developmental context in which Blacks go from childhood to adolescence, and adolescence to young adulthood, and young adulthood to adulthood. And as part of that experience, one is that, and this is the acculturative factor, is that Blacks are more accepting, have a more accepting attitudes, younger Blacks towards suicide. There are generation differences in coping. Younger Blacks are more likely to self-blame than system blame, which is, again, approaching what whites tend to do in the United States, the idea that structure doesn't matter as much, and we know structure does matter in terms of our life experiences, our work experiences, our educational experiences. There's a role for faithlessness and hopelessness, again, all part of understanding the social experiences of Black Americans, whether or not they're in close communities or just or in communities for which they don't feel that they have good connections with neighbors or connections to the Black church and traditional things. Great level of hopelessness. You still have, again, because you're talking about men and males, you're talking about help seeking is still seen as a weakness among some. But again, there's change and efforts to advance that. But then racism-induced gender role strains for these males are particularly important. Again, you know the social experiences of Black males in the United States related to work, related to education, related to future aspiration. Even if you get incarcerated, what does it mean to come back out? Consequences and challenges. And then, of course, access to lethal means. These things are all important candidate factors that we must look at, and I encourage you to either consider them in your scholarship, but also these are things you can discuss and try to understand in the context of clinical care, because individuals come in presenting with a lot of predisposing factors, and some of these things could be reflected in some of their precipitating factors that lead them into emotional crisis. So as I mentioned, a new generation of young Blacks are being raised in extreme developmental contexts that lack symbols of hope and appropriate coping styles, which helped earlier generations face the challenges of adverse situations. And I'll move this forward a little bit. A little work to show that this is true, looking at suicide acceptability. Just the idea that, again, even if you change the attitudes of the population, where you have younger generation of Blacks feeling that suicide is an acceptable response to life challenges, you find that in one study that we did, that if you combine that with hopelessness, I'm trying to get to the fact real quickly. I'm sorry, I had so much I wanted to share with you guys, that we find that that had changed over time. And we were looking at adolescents generally, that over time, more and more Blacks were accepting of suicide. It's okay to end your life if you are tired of living. This is what was done in the General Social Survey and indicated suicide acceptance. And we found that over time that was increasing. And particularly among the younger Blacks. So suicide acceptance among Blacks over time was increasing, and particularly for the younger Blacks. And then when we just did some logistic regression looking at suicide acceptability and suicidal behavior, again, we saw that that had a consequence when we did analysis. Let me get right to it. And we saw that when Blacks, again, were not only hopeless, all right, and have accepting attitudes, it elevated their risk for suicidality considerably, in contrast for those who were not hopeless. So if you were hopeless and have an accepting attitude towards suicide, you are more likely, more than 14 times more likely to make a plan to kill yourself than adolescents who did not. All right, so key point. I'm gonna skip the religion component because I think that's there. As I said, I'm over-prepared, and I know many of you have other things to do today. I want to leave you on one last thought here, and I'm going to skip over some of these structural issues. The idea of what I was showing before is that science matters. Who does the work, and the importance of advancing work to understand populations and structural racism. It's important to have scientists who are not only interested in that, prepared to do that work, and it matters. So I was just highlighting that. But the last piece I want to leave you with is this concept of how to human-to-human interaction. Now, in order to have racism, whether structural or not, you must racialize individuals, and we tend to do that. And there's enough scholarship dating back, again, not only beginning with Du Bois, but scholars who have really made this case, and many of you know this, that it makes the case that it's really inappropriate scientifically to continue to racialize populations. We have better or more exact terminology, whether it's caste, to say what is the thing that we're studying that makes a difference, that leads to disparities or leads to particular health outcomes. And it's not whether or not we are speciating, right, human beings, because the evidence suggests we don't have any subspecies of human beings, but we do that. And we do that not as a consequence of science, we do that as a consequence of eugenics and white supremacy propaganda that led us to put that into law and culture, and it's ubiquitous in our everyday racialization of human beings. So in many ways, to take an anti-racist approach is really, I'm going to skip past some of this, is that take an anti-racist approach is really to move past this subspeciation. And just to make the point real clear, race is not a social construct. Race is a biological construct. Race means subspecies. That's the synonym for race. Pull it up on your telephone, your watch, whatever you want to, and that's what it means. However, there's been an effort among those who really want to have racialized language and all that is pregnant with that, all that history, all that violence, all of that caste, all of those things, to make sure that we continue to racialize in our language. And that, again, furthers and makes it an intergenerational process. And we've been suffering from that. But we have really good terms to acknowledge the concept of Black people, Latino people, whatever social identity you have that has great value, it has meaning, but it's not race. And to the extent that we keep doing that, again, we're suffering because language matters. It's more than just spoken word. So sciences actually show us that positive and negative words not only affect us on a deep psychological level, but they have significant impact on the outcomes of our lives. So what is not and cannot be supported by science and is not supported by science, many on both progressive and not progressive points of view use the same tool. And that tool was birthed out of a process of a culture of hate. Dehumanization in the 15th century that led to the creation of chattel slavery, which led to the racialized language, because there was a need to justify that level of dehumanization and economic benefit to a group. The idea of white superiority, all these things were built in and intentionally done, and then was codified into cultural practice and laws. And even in science, we do not move past it. And then we lower the evidence threshold and say, well, you know what, it's no longer biological, let's make it social. But if the social structure is already built, you're going to have a tautology. You're going to find what you built. That doesn't mean racism is not real. Racism is, again, that racialization of people, and then the consequences for doing that for those individuals and the social statuses that you regulate them to and enforce with violence and with law. So with that, there's much more I can say, but I've stopped there because I used up a lot of time. So let me stop there, Tanisha, if you don't mind, and Catherine. There might be a question or two.